Welcome back to the deep dive. Today, we're plunging into a bit of a medical mystery. What happens when the immune system sort of develops an identity crisis, attacking the body using patterns from like 3 different diseases at once?
Yeah, we call that an overlap disease, and it really is the ultimate diagnostic challenge because you're not just looking for one specific illness, say lupus or scleroderma. You're looking at this multi-system storm.
A storm, that's a good way to put it.
Where features of one condition are sitting right next to features of another. It forces clinicians to solve a puzzle, but, the pieces keep moving.
Exactly. So our deep dive today is into mixed connective tissue disease, MCTD for short. And we're using the really detailed source material from a case study, a 32-year-old school teacher, Mrs. Kushi. Our mission here is to pull out those definitive immunological markers, map out this really confusing, overlapping symptom profile, and understand how precision diagnostics actually saved this patient, despite some really severe, life-threatening organ involvement.
It's a fascinating case because it highlights just how complex these conditions can get.
Okay, let's unpack this then. We should probably trace Mrs. Kushi's timeline first, see how this slow trickle of symptoms turned into, well, a flood of multi-system failure.
Yeah, and what's really striking here is the sheer duration. I mean, the length of time these symptoms were present. These weren't sudden issues appearing overnight. The source material shows her decline started years, literally years, before she got that final diagnosis.
Okay, so baseline snapshot first. She's 32, a school teacher, and critically, no family history of autoimmune disease, right?
Yeah.
That often complicates things.
Right, no family history mentioned. So the first clue, the thing she experienced the longest, was Raynaud's phenomenon. For 4 years, she noticed that when her hands got cold, her fingers would turn white, then blue, then red as the circulation came back.
Classic vascular sign.
Absolutely, a classic vascular signature.
And that didn't stay static, it progressed. About 2 years into this timeline, she developed distinct hand stiffness and swelling. It progressed to what the report actually calls sausage-like fingers. That already sounds like inflammatory arthritis, maybe.
He certainly points towards inflammation in the joints, yeah. And then the systems involved just broadened significantly. By the 1-year mark before diagnosis, she was reporting generalized fatigue, worsening joint pain, and significant proximal muscle weakness.
Proximal muscle weakness meaning difficulty with large muscles, like climbing stairs.
Exactly. Struggling to climb stairs, get up from a chair, that kind of thing. She also had trouble swallowing solids, that's dysphagia, and suffered from heartburn, too.
Okay, so we've got musculoskeletal, vascular, and now GI systems involved. And things got really critical in the last 6 months, didn't they? Breathlessness on exertion.
Significant breathlessness. And then in the final 3 months, facial puffiness, along with a photosensitive Meller rash.
Ah, the classic butterfly rash across the cheeks, the one you often associate with lupus.
That's the one. So when clinicians finally examined her properly, they noted all those historical clues were right there. The puffy face, the rash, visible early sclerodactyly.
Sclerodactyly, that's the hardening of the skin on the fingers.
Yeah, thickening and hardening of the skin and the tissue underneath. And her vitals were worrying, too.
Her oxygen saturation was only 92% on room air. That's low. And what really stood out in the cardiac exam description was a loud P2 and a parasternal heave. Can you explain those for us?
Yeah.
Because these sound pretty serious.
They are serious signs. A parasternal heave is basically when the doctor can feel, or sometimes even see, the right side of the heart pumping really forcefully, pushing the chest wall up. And the loud P2 is the sound the pulmonary valve makes when it snaps shut under high pressure. It's much louder than normal.
Yep.
Both are classic physical signs that tell the clinician the right side of her heart is struggling. It's working much too hard against severe high blood pressure in her lungs. That's pulmonary hypertension.
Wow. So that immediately links everything, the joint swelling, the Raynaud's, the muscle weakness, and now this dangerous heart strain. It's like a whole web of system failure.
It really is. And, that complexity brings us straight into the scientific evidence needed. It's one thing to see the symptoms, but you absolutely need the biochemical and immunological proof to sort of pin down the exact overlap disease.
Right. So what did the initial lab work show, just generally?
Well, the general flags for inflammation were definitely raised. Her ESR, that's the erythrocyte sedimentation rate, was high, 30 millimeter DAR. Her CRP was also highly elevated, and her CK, creatine kinase, which is a marker for muscle damage, was mildly elevated. Same for her LFTs, the liver function test, so confirmation of active inflammation and some muscle involvement.
And the physical evidence of vascular damage, the Raynaud's, that was backed up visually too.
Yes, exactly. They did nail fold capillaroscopy. found abnormalities, specifically dilated capillary loops in areas where capillaries had dropped out entirely. That's clear visual confirmation of microvascular damage, which you see in, well, quite a few connective tissue diseases.
Okay, here's where it gets really interesting, I think.
hmm
Moving past general inflammation to the specific immune markers that actually dictate the diagnosis.
Yeah.
She tested strongly positive for ANA anti-nuclear antibodies, which is common in autoimmune diseases.
Yeah.
But the crucial finding the report emphasizes was the strongly positive anti-U1-RNP antibody. Now wait, if she had that classic malo rash, typical of lupus, how important was finding this RNP antibody and pushing them towards MCTD instead? And what is RNP targeting?
That really is the pivotal question. The RNP antibody is pretty much the definitive smoking gun for MCTD. It targets a specific group of proteins, small nuclear ribonuclear proteins, or snRNPs. These are involved in processing RNA inside the cell, specifically RNA splicing. It's a fundamental cellular process. So when the immune system specifically targets this component, U1-RNP, it defines a unique disease mechanism. It sets it apart from, say, pure lupus or pure scleroderma, which have different characteristic antibodies.
Got it. So if the anti-U1-RNP positivity is basically required for an MCTD diagnosis, then the negative markers were just as important for ruling out the other main suspects.
Precisely. You need to look at the whole picture. Her anti-dsDNA was negative. That's the key antibody for SLE or lupus. Her anti-CL70 was negative, which helps rule out a pure diagnosis of systemic sclerosis or scleroderma. And her anti-Jo1 was negative, ruling out the most common forms of pure polymyositis.
So the body was clearly attacking itself, but not in a way that fit neatly into any one of those boxes.
Exactly. It had features of all three, but lacked the specific defining antibodies for any single one of them, except for the U1-RNP. That combination, the overlap features, plus the positive U1-RNP, essentially forces the diagnosis of mixed connective tissue disease.
So the diagnostic challenge was huge because she had the skin signs and arthritis, kind of like SLE, the finger swelling and difficulty swallowing, like scleroderma, and the muscle weakness and high CK, like myositis. And the RMP antibody basically said, yep, it's all three involved.
Absolutely, that's the classic MCTD picture. But in Mrs. Cucci's case, the complexity was really compounded by how quickly and severely her organs became involved.
Right, let's focus on those severe complications now, because this is where the management becomes, well, immediately life-saving. The sources highlight major issues in three separate systems, don't they?
They do. Starting with the respiratory system, she had interstitial lung disease, ILD. This was confirmed by a high-resolution CT scan, an HRCT. The pattern they identified was NSAP, nonspecific interstitial pneumonia. Essentially, the lung tissue itself is being scarred and damaged by inflammation. That directly explains her breathlessness.
And the consequences are clear. That lung damage leads right into the cardiovascular problems we mentioned earlier.
Directly. The lung fibrosis and the inflammation in the lungs' blood vessels caused severe pulmonary hypertension, which, as you pointed out, was causing that dangerous heart strain. Her echocardiogram measured the pressure in her pulmonary artery at 50 millimilla Hg. That's critically high, needs immediate action.
And we shouldn't overlook the GI issues either, the constant discomfort and potential danger there.
No, definitely not. That difficulty swallowing. It was confirmed as esophageal dysmotility using a barium swallow test. Her esophagus just wasn't moving food down properly, and that resulted in severe GERD, gastroesophageal reflux disease. So, think about it. This woman was managing three major system failures, respiratory, cardiac, and GI, all at the same time, plus the joint, skin, and muscle problems.
That scale of multi-system failure just means the management plan has to be incredibly comprehensive and highly targeted. It's not just about treating a rash or some joint pain anymore.
Oh, far from it. The plan really needs a holistic approach. It starts with patient education, helping her understand the multi-organ nature of this thing, and general preventative care, like being really strict about avoiding cold exposure for the Raynaud's, plus nutritional support, specialized physiotherapy.
And then you get into the pharmacology, the drugs designed to modulate that rogue immune system and try to rescue the damaged organs.
Correct. For the widespread issues, the arthritis, muscle inflammation, skin involvement, they typically use general immunosuppressives, things like corticosteroids to knock down acute flares, and then longer-term maintenance drugs like hydroxychloroquine, maybe methotrexate or azathioprine, depending on the main features.
But the really severe organ damage needs the special forces, so to speak.
Exactly right. In her case, mycophenolate mofetil was prescribed specifically to target the inflammation and scarring in the lungs to try and halt the progression of the ILD. That's a potent immunosuppressant often used for organ-specific issues. And the severe pulmonary hypertension needed its own dedicated treatment, aggressive vasodilation. Drugs like sildenafil or maybe specific endothelin receptor antagonists. Their job is to relax the blood vessels in the lungs and bring that dangerous pressure down.
Plus things for the other issues, presumably.
Oh, yes. Proton pump inhibitors, PPIs for the severe GERD, calcium channel blockers to help manage the Raynaud's symptoms.
It's truly astounding when you list it all out. They're simultaneously treating joint inflammation, trying to save lung tissue, lowering that critical blood pressure in the pulmonary arteries, controlling muscle attack, managing reflux. The coordination required to manage, what, like 8 separate organ domains is just immense.
It really underscores the central challenge of MCTD. You aren't just treating one inflammatory disease, you're engaged in this constant process of damage control. You're modulating the immune system while simultaneously trying to reverse, or at least halt, the consequences of its attack on vital organs. It's incredibly complex.
So, okay, what does this all mean for us wrapping this up? Our deep dive into Mrs. Cushy's case really confirms that mixed connective tissue disease is, well, it's much more than just a random collection of overlapping symptoms. It is a distinct, defined diagnosis. And it's confirmed specifically by that anti-U1 RNP positivity. And that specific antibody test proves absolutely crucial because it holds true even when the disease shows up with these really severe, life-threatening complications like
Yeah.
ILD and pulmonary hypertension.
Right. The clinical presentation can look like severe lupus or severe scleroderma or severe myositis or bits of all three, but that antibody profile defines it. It's the unique combination of the parts identified by that key antibody that defines this whole disease category.
Which brings us to a final provocative thought for you, our listener, to consider. Given that this disease is defined by these constantly shifting features, borrowed from SLE, scleroderma, and polymyositis, what challenges might arise for clinicians in deciding when to escalate treatment?
That's a really important point. How do you decide? If the patient's symptoms shift, say, from a dominant scleroderma pattern 1 month to looking more like lupus the next,
How do physicians figure out which part of the disease they're currently treating most urgently, and how aggressively they need to intervene right then?
that constant state of clinical uncertainty, weighing the risks and benefits of different potent therapies based on a changing picture, that's the day-to-day reality of managing MCTD. It's a constant balancing act.